Your patient has a CSF leak and a bad headache. You've tried bed rest, fluids, and caffeine, but it's not helping. What's next? It's time to consider an epidural blood patch. This simple procedure provides an instant fix for the majority of post-dural puncture headaches, and in the next few minutes, we'll show you how to do it safely and effectively. A spinal headache, or post-dural puncture headache, is caused by leakage of CSF through a hole in the dura and arachnoid membranes. This typically occurs after a lumbar puncture or following an accidental dural puncture during epidural placement. The CSF leak in the lumbar spine decreases the intracranial CSF volume, and since the skull is a fixed space, something has to replace that volume. That's accomplished by cerebral arterial vasodilation, and it's that vasodilation that causes the headache. It's also been proposed that the brain sags with the lower volume of CSF, and this puts traction on the meninges. Therapies for spinal headaches are aimed at either reversing the cerebral vasodilation, like with a sphenopalatine ganglion block, and I'll leave a link to that video, or plugging up the leak in the dura with a blood clot. And that's the whole point of the epidural blood patch. Take some of the patient's own blood and put it in the epidural space so the fibrin clot seals over the hole. Spinal headaches are more likely in young females and happen more often with bigger needles. A 25-gauge spinal needle carries a post-dural puncture headache incidence of around 1%, whereas if you put a 17-gauge hole in the dura with a 2E needle, that incidence rises to 75 to 80%. Holes made with cutting needles don't heal as quickly and therefore are more likely to provoke a spinal headache than non-cutting or pencil point needles. The diagnosis of post-dural puncture headache is clinical and involves the presence of a new headache within 5 days following a witnessed or suspected dural puncture. Patients often describe intense squeezing pain bilaterally in the frontal and/or occipital region, classically aggravated with sitting or standing, and relieved when lying supine. Neck pain, dizziness, and nausea and vomiting are common symptoms, and some patients have symptoms such as auditory impairment, photophobia, or blurred vision due to traction on the cranial nerves. Even though 90% of spinal headaches resolve within 7 to 10 days, these can be disabling, especially to a mother who's trying to care for a newborn. Conservative treatment with bed rest, oral analgesics like acetaminophen and NSAIDs, hydration, and caffeine, which is a vasoconstrictor, should be initiated for most patients, but frequently these just don't work all that effectively, and we'll typically talk to the patient early about epidural blood patch and pull that trigger when he or she desires. Epidural blood patches work in two ways. First, pushing 20 mL of blood into the epidural space compresses the dural sac, increasing the CSF volume in the skull. This is why patients frequently say they have instant relief. Following this, the epidural blood clot helps to seal the hole, preventing further leakage, and actively contributes to healing of the meningeal tear. Epidural blood patches should be avoided in patients with the usual neuraxial contraindications: local infection, coagulopathy, patient refusal, or neurologic abnormalities like myelomeningocele, tethered cord, or increased intracranial pressure. This is best done as a two-person job, one to access the epidural space and one to draw the blood in a sterile fashion. It's nice to do this in the sitting position, but some patients can't tolerate the headache when sitting, and in those cases we'll go lateral. Start by sterilely prepping the patient's back, as well as the arm that you plan to draw the blood from. A tourniquet should be placed on the upper arm prior to prepping and draping out the antecubital fossa or forearm. Once both sides are prepped and ready, the first operator begins to access the epidural space. Local anesthetic is infiltrated at the proposed puncture site, which should be either the same level as the original puncture or one level below. A 2E needle is then inserted through the skin and advanced through the interspinous ligament. Here we see the operator performing a loss of resistance technique to saline. With each small advancement of the needle, she tests the resistance to injection by tapping on the saline-filled syringe plunger. For the first several centimeters, the needle tip position within the ligamentous structures resists the injection of saline. This pattern is repeated until the needle tip passes through the ligamentum flavum. Once that happens, we see the saline pushes easily, indicating that the tip is in the highly compliant epidural space. At this point, the second operator should cannulate a vein through the prepped skin and draw off a total of 20 mL of blood. We'll typically use an 18-gauge IV cannula to make sure it draws back easily. You can use a single 20 mL syringe, or in this case, two 10 mL syringes. The total volume of blood required to get a good effect is typically between 15 to 20 mL. Pass a syringe off to your colleague. He or she will then attach it to the epidural needle and begin to slowly inject. You should aim to inject the entire 20 mL of blood, or until the patient begins to report backache, discomfort, or radiating pain. There appears to be no benefit to injecting more than 20 mL. And that's it, you're done. We used to instruct patients to rest supine for 30 minutes after an epidural blood patch. The evidence for this is mixed, but patients should be advised to avoid heavy exercise, lifting, and bending for several days. The success of epidural blood patch is about 85%. That's pretty good, and as mentioned, the relief is usually very rapid. If your patient is in the unlucky 10 to 15% who don't get substantial relief, you can repeat the procedure and expect it to be effective in about 90%. Receiving an epidural blood patch is very well tolerated by most. However, like everything in medicine, complications can occur. These include the usual ones associated with neuraxial needling, like infection and bleeding. It's obviously very important to be stringently aseptic when injecting blood into the epidural space. In addition, blood can track along nerve roots, causing temporary radicular irritation. Mild back pain is common after epidural blood patch, but the biggest risk is causing another dural puncture. There are often anatomic reasons why some patients get a wet tap in the first place, and having someone else do a second epidural is no guarantee that it won't happen again. These risks should be discussed with the patient ahead of time and weighed against the benefits of fixing the headache and just having conservative therapy. I usually try my best to avoid epidural hematomas, and that's essentially what a blood patch is. But when done correctly for a spinal headache, it can be a simple and effective fix.